Good morning. We are all happy that we have so many rising stars in the room, and I see that there are some already raised stars also, so it's very nice for us. So I will talk about the brain trauma. Apart from the goals listed above, I will concentrate on the fundamentals and the tricks that you can hardly find in books, but can be very helpful in your professional life. Well, we do not have the voting system here, but to keep you awake during this lecture, I have a couple of questions to you. So before every question, you will see this image with the hands, so please vote with the hands, and please take an active part in this lecture. Well, acute head trauma, how big is the problem? This is a problem because traumatic brain injury results in more death than does trauma to all other anatomic regions, and we have to remember that it's a leading cause of death in the young population, let's say relatively young population under the 40-45 years. But more problems actually we have with these people who survive. In the recent literature, I found the figure almost 200,000 every year new brain victims cannot go back to the social life because of the fatal injuries, and the best example is the tragedy of former Formula One driver at the moment in Grenoble. So if we look into the statistics, motor vehicle accidents and falls represent up to 80% of acute head trauma hospital admissions. So remember that if you have the patient from the accident, motor vehicle accident, or just a victim from the fall, just always consider that he can have the brain trauma injury. So let's say Mrs. Smith is admitted to the hospital after the head trauma. So what do you prefer? X-ray, or can we use CT, or immediately send to the MR, which is the best method? Well, I do not have good information for the fans of the X-ray, because the X-ray, well, we do not have any room for the X-ray after the brain trauma. Why? Because we have only bone information, if any. Remember that a lot of fractures can be missed on the X-rays, and we do not have any information at all about the brain injury. So in a person after the head trauma, forget about the X-ray. It's a waste of time. There is no room for the MR neither. Usually it's away from the emergency room, time-consuming, long examination, but remember that this method is non-sensitive to bone injuries and definitely is less sensitive to very fresh extravasation. So it's accepted worldwide. The CT is number one. You can find the CT in every corner in the city. It's inside or very near to the emergency room. It's quick and easy to perform. It can be the part of the multi-trauma protocol, which is very often used. Remember that CT is the most sensitive method to the bone injuries. And what is the best advantage of the CT? It immediately detects intracranial hemorrhage that might require neurosurgery, like just here. Well, how to perform the head trauma CT. Before, look always on the scalp, or look at the head of the victim. Because if you see that there is a large subgaleal hematoma or skin laceration, it is a strong indication that the force which was during the accident was great, and it's very probable that under the subgaleal hematoma you'll have the fracture, and under the fracture there is always the risk that you will have the epidural hematoma. So how do we perform? We always start with a scout view, and please take 5 or 10 seconds for the general look, what happens with the head. I can assure you that just only from the axial images alone, it would be very difficult to tell, what is the kind of foreign object which is impacted in the bony face. And this is the chicken cutting device in the middle-aged woman who slipped down in the kitchen. So please always take 5-10 seconds to look at the pilot. Then we move to the normal proper scanning. And non-contrast CT is mandatory. Remember, don't use contrast media immediately. We have to cover the area from C2 to vertex in caudalocephalad scan direction. Always use the minimum possible collimation and pitch less than 1. How many radiographers do we have here in the room? Oh, there are only a few. It's right, okay. Well, use always minimum possible collimation, because then we can use reconstructors, and the reconstructors we use for posterior fossa 3 millimeters, 5 millimeter slices above the tentorium is quite enough. If there is any clinical suspicion that something is wrong with the cervical spine, we have to extend our interest, our area of interest, and we cover the area from TH1 to vertex with exactly the same, all these details. So the head and the cervical spine will be covered with one sequence. There are very rare indications for the contrast media just in the head trauma. I think there are just mainly 2. The first is suspicion of cerebrovascular injury, and the second one is the exclusion of the ruptured aneurysm as the cause of the fall, and we will move to this a little bit later. If we administer contrast, remember that in the post-contrast series, we should cover the area from the aortic arch to see all the carotid vessels and vertebral vessels which can be injured during the accident, and of course the caudalocephalad scan direction. And this is the example. On the left you can see very, very subtle fractures in the sphenoid corpus and the apex of the pyramid, and this is the result. You see that there is a carotid fistula. Well, just 3 things about the skull fractures. Well, don't forget about using MPR formats. Why? Because some of the fractures, which are very subtle and tiny, can be visible much more better in other planes than the axial ones. And this is the example. You see that there is a fracture here at the greater sphenoid wing, but it's much more better seen on the sagittal. Well, look always for the present compound fractures like here, because, well, you should alert the neurosurgeon. I mean, these usually require the neurosurgery. It doesn't mean that the neurosurgery must be done immediately, but leaving this injury alone will result in a post-traumatic epilepsy, because there is a permanent compression of the frontal lobe. And pay a very, very careful attention to the temporal bone and skull base fractures, because there is always a risk of the vascular injury, and this is the example. So now we move to the brain injury. So always look for 2 things. Look for any hyperregions, look for any hypo. Hyper, in the patients after the trauma, they represent the extravasated blood. But the hypo areas are also the matter of our interest, because they are the indicators either of ischemia or the edema. And these 3 images show the whole variety of these findings, and this is an example of the newborn who was delivered by the vacuum device. Well, one thing we have to be aware of, that traumatic brain injury is not one-time event. It doesn't mean that, what could have happened, it happened just at the moment of the injury and everything is over. Well, the primary injury, it's all the injuries that occur at the moment of impact forces and progresses rapidly. But immediately, at the same time, secondary injury starts. This is a cascade of different biochemical reactions that last minutes, days, weeks, and months. And in fact, this secondary injury, it's very, very hard to tell when it will finish. Because of the given time of the lecture to me, I will concentrate on the primary injury only. There is a lot of findings that we can detect in primary injuries of the brain, and we will go for them. So, I have the question for you. This is the CT performed in the motor vehicle accident 45 minutes after the accident, and this CT image presents the one chronic epidural hematoma, the second acute epidural hematoma, the acute subdural hematoma because it crosses the midline, which is seen very well here, or acute massive brain contusion. Who is after the first one? The second one? Okay, 4, 5. Acute subdural hematoma. Okay, and acute massive brain contusion. It's all right, so only 10 people answered, you know. It's right, so this is the acute epidural hematoma. Well, remember, the epidural hematomas do not cross the sutures because periosteal layer of the dura adheres strongly to the suture, and it doesn't allow to go the hematoma further, but they can cross the midline because the dura forms the outer wall of the superficial sinus. So this is the classical example of the epidural hematoma. What we have to know that they are the hyperdense area between the inner table of the skull and dura. They are usually biconcave in shape, often result from a skull fracture. So above the hematoma always looks on the bone window for a skull fracture, and pay a particular attention to the temporal region because the squama of the temporal bone is very, very thin. It's very, very risky to be fractured, and underneath there is a meningeal middle artery which can be injured. Well, also what you have to remember is that they can grow rapidly. This is the CT image after 1 hour after the accident, and such rapidly growing hematomas always carries the risk of these hypodense area, which means edema, and this is a fatal finding here, the hypodensity of the pons, and this is the fatal finding because the prognosis for the outcome of the patient is very, very, very bad. Well, so how many of you are just on the night duties already? None. But if you will be, remember that we have to be familiar with the findings suggesting early surgical evacuation. What does that mean? That if you see them, you should use your phone and phone the neurosurgeon. So if you will notice that the hematoma thickness is more than 15 millimeters, or the hematoma volume is more than 30 cubic centimeters, or the midline shift is more than 5 millimeters, always call the neurosurgeon. He will decide whether to operate immediately or not, but you must phone the neurosurgeon. Also, very dangerous sign is what we call the swill sign. You see that inside of the hematoma, you have the large area of the hyperdense blood. It doesn't mean that the hematoma is old. It indicates that it's ongoing hemorrhage. What does it mean? That during the examination, the hematoma is still going larger. And this is the classical finding that requires immediate neurosurgery. Well, the second on the list is subdural hematomas. Well, usually venous in origin. They are the hyperdense area along hemispheric connectivity. And you see just here 3 examples. But remember, they can be tricky. It means that look at the first image, and on the first day after the accident, this is a hyperdense area on the on the right side. After 4 days, the hematoma is slightly more isodense and is completely isodense in the day 10th. Why is it so? Because remember that the hematoma density progressively decreases due to the protein degradation within hematoma every roughly 5 Hounsfield units per day. So if you do not operate the hematoma, it is very probable that after 9 or 10 days, it will be isodense to the cortical layer of the brain, so it can be very difficult to detect. Also, some acute hematomas can be iso or hypodense, and you can encounter them in anemia patients after coagulopathy and in the patients after thrombolysis. They can also be very subtle. So subtle, it means they are very, very narrow, like just here. So they are quite easy to miss when using standard windows. What I mean by standard windows is a bone window and the brain window. So I always recommend all my residents to go also for the subarachnoid window. I mean the window that subarachnoid space is very well seen. So all my residents will evaluate the head after the trauma on 3 windows: soft tissue window, brain, bone window, and subarachnoid window, to see if there is any extravasated blood in the subarachnoid space. Well, so we move to subarachnoid space, traumatic subarachnoid hemorrhage. Well, you can learn and read a lot from the books. Well, the subarachnoid hemorrhage, there are the hyperdense area, conform the morphology of cerebral sulci and cisterns. But if you notice the massive traumatic subarachnoid hemorrhage, well, you have to remember that you have to rule out the rupture aneurysm. If the patient is conscious, you can ask the patient, and the patient will ask you that, I had the worst headache in my life. In other words, if the patient is unconscious and you see the massive subarachnoid hemorrhage in the patient after the trauma, this is the always indication for the CTI. I already mentioned in the beginning. Why? Because the clinical scenario could have been like this. The patient had the intracranial aneurysm. It ruptured. It bled to the subarachnoid space. It was a sudden loss of consciousness of the patient that resulted in the fall of the patient. So we have the accident, or he was the driver and he hit another car or tree, and you can have the fracture and epidural hematoma. So this is the case. You see a lot of blood, and remember, if there is a lot of blood in the circus of Willis, at the level of the circus Willis, there is a strong indication that it could be that it was the rupture aneurysm. So this is the aneurysm. Of course, it can be presented in many, many ways. And, of course, what we can do is that we treat this aneurysm immediately. So, cortical contusion. Cortical contusion are the small focal areas of hemorrhage which are located usually peripherally in the brain. Remember that in 50% of the patients they can grow. And where do we look for them? We look for them mostly in the inferior frontal and temporal lobes. Why? Because the etiology of the cortical contusion is that the brain parenchyma is bruised by the direct contact with the inner surface or inner table of the skull, and this inner surface in frontal bone and temporal bone is irregular. So during this mechanism of the injury, the brain is compressed by these irregularities, and you can find the local cortical contusion. Well, if the impact was much more higher, well, the intracerebral hematoma can develop. And remember about 2 things, because the others you can find in the books. Up to 80% of the hematomas reach the maximal diameters in 12 hours after the trauma. So don't be astonished. The neurosurgeon or neurologist will ask you to repeat the CT after the trauma 12 hours, because he will see what is the general size of the hematoma. And also, they may develop in previously normal brain parenchyma, and this is what is called delayed traumatic intracerebral hematoma. So these 2 things you should be aware of. Well, and we move to the last one. traumatic axonal injury, so this is the abbreviation TAI, it's not DAI, because in literature you can find a lot of abbreviations connected with the axonal injury, DAI. After the trauma, you have the traumatic axonal injury. It's not a diffuse process. Traumatic axonal injury is strictly focused one, and with different modalities we can, well, show where are these locations of this injury. How does it come, that the patient has the traumatic axonal injury? It starts with the tearing and stretching the axons at the moment of injury, and this starts the activation of different enzymes, and this activation of these enzymes lasts and ends with the transaction of axons with myelin and breakdown products. Well, of course, it's a very, very short story. Traumatic axonal injury is very difficult to diagnose with the CT because we can only detect the lesions which are hemorrhagic, and only 10% of the patients have hemorrhagic lesions, in fact, in traumatic axonal injury. They are very, very small. Usually, they are located at the gray matter junction, but if they are moving more centrally to the brain, it means that the outcome of the patient is much more problematic. I mean, the clinical status of the patient is much more worse. So if we find that there are the hemorrhagic lesions in the corpus callosum or in the brainstem, the prognosis of the patient decreases very, very sharp. In traumatic axonal injury, we have the role for the MRI. So the question for you, which single, I mean only one, MR sequence is the most sensitive in detection of brain parenchyma hemorrhage lesions? T1 with triple dose, FLAIR, diffusion, or susceptibility weighted imaging SWI? So who is for the first? T1 with triple dose? None? Oh, well, there is one, but the hand immediately disappeared. Just please vote, Well, we learn all of the time, so there are no stupid answers, Just don't be afraid to raise your hands. FLAIR? Okay. Who is for the diffusion weighted? And who is for the fourth one? Yes, the majority. Yes, and the majority is correct. The single MRI section with the most sensitive in detection of brain hemorrhagic lesions is susceptibility weighted. It was already told during the first lecture. And this is the example. Look, this is the patient after the trauma. On T2, you have only one lesion here on this level of scanning. On the FLAIR, you have one. On the T1, you can hardly notice anything. And look how many lesions are in the EWS. Well, but remember that in traumatic axonal injury, there are not only hemorrhagic lesions, there are also the non-hemorrhagic lesions, and of course the diffusion-weighted imaging is much more better than the others. T2, FLAIR, and see how many lesions you can see on the DVI. So, let's say that we have 5 basic sequences in MR in traumatic axonal injury. So it's T1, T2, FLAIR, diffusion, and susceptibility-weighted imaging. So just to keep in memory, I have the question to you again. The phrase Big Five is synonym of 5 MRI sequences used in traumatic axonal injury. Title of Dave Brubeck's masterpiece. I think that this question can be answered only by already raised stars. 5 new 20th century world wonders, or 5 big African animals. Who is for the first? Right, okay, quite a lot of people. 20. Who is the title of the Dave Brubeck? None. 5 new 20th century world wonders by the UNESCO. 5 big African animals. Right, not too many. Well, yes, you are right. Those who are 5 big African animals, 5 MRI sequences, and not Big Five. Big Five, Big Five, you can use this name only for the Try an MRI. Title of the day, Broberg, no, it was not Big Five, but Take Five. There are, for the people who are interested in jazz, there are 7 new 20th century world wonders, not 5. And of course, African Big Five is the dream of every hunter or photo hunter. It's the lion, African elephant, Cape buffalo, leopard, and rhino. Okay, so look at this image. 8 days after the trauma, after heart transplantation, clinical conditions almost very good. This CT image represents normal brain, bilateral frontal cortical heterotopy, compression of anterior horns of unknown cause or bilateral subdural hematomas in frontal areas. Just look at the image. Okay, so who is voting for the, no, I don't, okay. Who is voting for the first? Normal brain? None. Bilateral frontal cortical heterotopy? None. Compression of anterior horns of unknown cause? 1. So all the rest are for the bilateral subdural hematomas? That's right. Very good. Rising stars are already raised, Yes, it's the bilateral subdural hematomas in frontal areas. So, well, one of the tricks in the patients after the trauma, and not only in the trauma condition, is the estimation how wide is cortical layer of the brain. And in majority of patients, disregarding of the age, the width of the cortical layer should not exceed 4 centimeters. If there is more than 4 centimeters, there is an indication that there is a pathology in this region, and we have to detect it and evaluate it, what is the nature of this. So this is the normal brain. This cortical layer is not more wider than 4 centimeters. Look at this image. This is 3. This is definitely more than 4. And if we look closely to this picture, look, there is a subgaleal hematoma here. There is a very, very subtle subdural hematoma. And there is probably compression of the left ventricle. I say probably because we are not always sure what was the positioning of the head during the examination. So look at this picture. You see that this distance definitely is more than 4 centimeters. And the reason for this is that in both frontal areas, we have the subdural hematomas. Sometimes to delineate the subdural hematomas, we have to administer contrast media to see the clear merging between the surface of the brain and the hematoma. So, just for the last, have a quick look at the image. 5 seconds, I give you. Oh, well, 10. So my question is, on which side of the patient are the major post-traumatic lesions? I repeat it. On which side of the patient are the major post-traumatic lesions? So, who is voting for the right side of the patient? Okay. And who is voting for the left side of the patient? Yes, the majority. Well, those who voted for the right side, they are right. Look where the letter L is. The letter L is here. Well, it's not a joke. It's not a joke. I will explain it. The letter R is on the right side. So it means that this, what we see on the left side of the picture, is in fact the left side of the patient, and this is the right. Well, normally, all the images are coded that on the left side of the image, you have the right side of the patient. So, for example, this hematoma is on the left side, is normal. So the question is, how could this happen? And I wait for the possible explanations from you. Fault of the technician? It's almost impossible because, all the machines are coded automatically. So when you go with the head first, you always have the right on the left side. So what is the possible explanation? Yes, please. Sorry? The patient lying on the stomach? Well, typically, no, the frontal lobe will be down. Right? The frontal, so. Okay? This is the most common explanation. For the better, this patient has a lot of tubes, better access to the abdomen, so he goes with the legs first to the gantry. So then you have the changing of the size of that. Of course, it could be changed by the technician also, but we prefer to have, because sometimes technician forgets about it, sometimes not. So if we know when there is a command legs first, we know that this is the right or left side of the patient. So my advice is pay careful attention to R and L letters, because if you would say that these lesions were on the left side of the patient and the surgeon will see it and will operate on the left side, you are in the big trouble and the neurosurgeon is in the big trouble. So thank you very much. And for the summary, just 6 sentences. For epidural hematomas, remember that they can grow rapidly. Remember about the ongoing hemorrhage, the swill sign. What are the indications for the surgery? From subdural hematomas, remember that they can be the tricky ones, eyes or hypodense. If you see the traumatic subarachnoid hemorrhage in the patient after the accident, always you have to rule out the aneurysm as the cause of the accident. Intracerebral hematomas, pay attention to frontal and temporal lobes because that is the place they are very often encountered. In traumatic axonal injury, more pericentral, worse prognosis, and this is the role of the MRI. And the 6, keep your trauma diagnostic manual book in your pocket or on the desk. It can be very helpful. Thank you very much.